Just to start off with,
Where that sit in?
please make yourself comfortable. We do have water. We have a few snacks over here on the table. If anybody does need to make use of the facilities, they were right outside the front. As you came in the front door, they would have been to your left, so leaving, they're to your right. And at any point in time, you do need to leave, you need to step out for any reason, feel free to do so. This is not a classroom. No one expects you to raise your hand and wait on to be called. The goal of tonight is to have a conversation, and hopefully a conversation with people in the community, because I can talk to people who have resources fairly easily. Honestly, talking to people in the community who have real issues, and everybody in the community has real issues with this, is harder for me to reach out to. I know just by my presence, generally, I change the tone of most every conversation I'm in. Lucky me. My name is Kevin Patterson. I am the county manager. My goal here tonight is just to welcome everyone. We'll be asking our panelists who actually know a whole lot more about this than I do to come up, introduce themselves. But we had our first meeting was in Laurinburg in November. We waited till after Christmas to get through the holidays for this one. We will be having another meeting in February at Laurel Hill Community Center, February 23rd at 6 o'clock. So if you know of anybody who is not available to make this meeting and is still interested, we are planning on having another one. That is not necessarily the end of the conversation. We need to keep the conversation going and hopefully changing the tone based on the conversations we have at these meetings. Part of this, what spurred these meetings, of course, Scotland County did join in with numerous counties across the country, numerous other states, in the opioid mass litigation lawsuits. We did prevail in that and actually received national settlements. There was another settlement, a much smaller settlement, that happened within the last few weeks. But with this, Scotland County's portion of the major settlement is about $2.8 million, just shy of $3 million, but that is over a 17-year period. So we've received $300,000 so far, and we will receive an annual payment of about $125,000 a year. And these already go to opioid and really substance abuse issues, looking to go to something that can actually provide services and benefits to members of the community. Now, whether that's on the institutional side, supporting the services provided by our mental health providers, by our healthcare providers, or any other thing, we are still looking at this. I have regular conversations with other county managers, with associations across the state, and right now a lot of counties are still trying to sit down and try to figure out the best ways forward. Drug addiction is something that everyone in this community is affected by one way or the other. I know every household, you may be fortunate enough to have a household that is not directly impacted. You don't have a member of your household that does have substance abuse problems. But it probably would not take anybody any time to think of someone within 2 steps that is directly impacted. Also with it, there's always the concept, or a lot of people love talking about opioids or drug abuse as, well, they're just addicts, they're homeless, they're those people, not me. Until you have someone in your family who's suffering from it, and then you keep quiet about it. With it, opioids and any other substance abuse, if every study out there shows it does not care if you're a male or female. It does not care if you are white, black, Indian. It does, whatever nationality you are, it does not care about whether or how much money you have in the bank. The incidence of substance abuse, substance misuse is fairly consistent across every demographic. We all know people who are pillars of the community who have lost people. And chances are everyone in here is in this room because they know people, or they may be suffering silently with their own current difficulties with it. I know it's touched my family, and I'm sure it's touched everyone else's. That is the real importance of having a conversation and making sure that we have an open dialogue. And when we get into it, if anybody does open up, the people in this room are here to help as much as we can. But tonight is really about listening and finding out what are some of the untapped possibilities that we can help create for you, to provide support to your families and to the families of everyone else in the community. Because whether you're suffering in silence or, just, dealing with other family issues, there are other people that this is repeated time and time again. So actually, at this point in time, I would, because I am terrible at introductions, I'm actually going to ask some of our panelists to come up, and then we'll start with introducing ourselves. I'll actually start with our EMS director.
Hey, good evening, everyone. My name is Robert Sampson. I currently serve as the Scotland County Emergency Services Director and Emergency Management Coordinator for Scotland County.
Good afternoon, everyone. My name is William Sellers. I work for East Point MCO. In case you're not familiar with the MCOs, there's 6 of them in the state of North Carolina. We're located right here in Lumberton, but we serve 10 counties, and we're thrilled to be here in Scotland County and to support the efforts with our community forums. And Kevin said it so well. We really had a great gathering, our first one before Christmas, and we're going to continue that. We are not going to suffer and die in silence. I think that the conversation starts here and it starts now, and we're just thrilled to be a part of it tonight. Real quick, I do community relations. So if there's anything that you need as far as behavioral mental health type things that you might need for your agency or individuals, we offer a number of things, trainings, services through our provider network. I'm your guy. Please reach out to me. I have some cards over here on my table. Please grab one of those, and it has my personal cell number. I want to be available to you and make sure that we work together and address these issues that come up.
My name is Mary Susan Baggett, and I am with the North Carolina Geriatric Adult Specialty Team, which is with East Point MCO. And my role is to go out to the community and provide some discussion, some presentations, allow folks to ask questions about a variety of topics, including substances, everything dealing from emotional health and brain health, do education on dementia and mental illness, as well as substance and prevention and recovery. So I can go out to churches, I can go out to different types of programs and resources. All of that is free as part of the programs and supports that we provide through East Point. So be thinking about that. I also have contact information in case you have an interest. I do a program, a discussion specifically on fentanyl, and then I have some others on some other classes of drugs as well, and then specifically on recovery and so forth. So if that's something that you might have a group or church that might be interested in just hearing some more information, that's what I do. Okay?
And hello, everyone. I'm Shelley Lowry. I'm a family physician, and I'm the Chief Medical Officer at Scotland Hill.
I'm Amanda Locklear. I work with Stevens Outreach. We currently have 3 locations, one in Lumberton, Fairmont, and Laurinburg, where we do mental health and substance abuse. I am a peer support specialist. I work with consumers that have, whether it be depression, whether it be drug addiction or opioid addictions. I work with them, give them resources to try to help them get on the road to recovery. We help them with housing. We have therapists, intensive home therapy, in-center therapy. We have medication management. I mean, there's so much that we do have to offer, for individuals that's suffering from depression, substance abuse, or whatever their problem is.
My name is Korea Rogers, and I'm working with Civil Outreach. And I work the mobile crisis unit, mobile units. And what we do on there, we go to different locations. On Mondays, we're at the DSS in Laurinburg. Tuesday, we're at Biggs Park Mall in Lumberton. Wednesday, we're at DSS. Thursday, we're in Red Springs. And Friday, we're in Fairmont, in Rose's parking lot. And every other first and third Saturday, we're in Rose's parking lot in Fairmont. Our hours are from 9 to 4.
And with that being said, with the crisis, the mobile unit, when they set up this unit, if someone comes in, if we have an individual that's reaching out for help, we can bring them in this mobile unit and actually do the assessment via computer. We will be able to call a doctor, we'll be able to call a therapist to do their assessment right there. Because a lot of people, if you see them on the streets, they might come to you right there, but they're not going to that office. So we try to make it very comfortable so they can go in there and, do privacy. It's privacy. And we do that a lot. We have people coming on there. So.
Is the unit out here out front?
The unit is outside, and if anyone would like to take a tour of it, we'll be glad to show you around it. So, okay, thank you.
One question for you on the mobile unit. If I have a family member who I know is suffering, can I come and talk to you?
Yes.
And do I need an appointment? Does it cost me $400 to come?
No, you just come.
And this is something, yes, I knew the answers to these questions, but, and this is something that Stevens Outreach is working with East Point. You've been in implementation
Since July.
Since July. And honestly, I will tell you, they're not busy enough. So, and it's not because of lack of trying, but with it, please encourage, pass the word with that we can have. Also, if you have organizations, because I know we have at least one member of the clergy here who may have a church or something, if there are other communities, other locations that might be good to set up, once a month, once every other, let us know, and we're happy to have those conversations, because they want to be as close to the people in need as possible. Coming into social services for those benefits is beneficial. They have a high volume of traffic, but you know what? Someone might go off and be able to get them to go to the family church a whole lot easier.
And we do have flyers, and it does show the day where we are on certain days with that mobile unit. So if you want to pick one of those up, but please pass the word once you get the flyer and you get the dates. Just spread the word. Thank you.
And one question, because I know we talk about someone who has geriatric services. And of course, when we talk about drug addiction or even drug misuse, is not something that is age dependent, but that and also a significant issue that does face a number of people who are elderly, who might have physical issues or mental issues where they can easily become confused. They could misuse this. Hold on, I've not taken my statin or my cholesterol medication today, so now I'm going to remember this. Wait a minute, I've taken that third dose of pain medication that I had for my shoulder that I should have thrown away 3 years ago. So there are a number of accidental overdoses that happen as well as drug use. So that's another reason why we want to invite in a number of our providers. And also they can provide educational opportunities for people in bridge clubs, churches, things like that, just to have those conversations.
Kevin, we have another one of our exhibitors, vendors here with Robinson Healthcare Corporation. This is Ms. Lamar Chandler, and if you would share with a little bit, this is another resource, a great resource that a lot of people don't know about. And so if you'll just share a couple of minutes about what you do and what you're sharing with us tonight.
Okay, hi, I'm Lamar Chandler with Robinson Healthcare Corporation, and I'm a prevention specialist and SPIF coordinator for Columbus, Scotland, and Robinson County. So Robinson Healthcare is pretty much a community care center that we provide primary health care. We also provide healthcare services within the community for substance use. We have different various centers where women and children can go, or we have a men's facility as well. We also have a doctor site in Scotland County. It's right there in front of the hospital. The Scotland Healthcare Center. It's a primary healthcare doctor. And tonight we have just a few things here that we are providing for Scotland County through our SPIF grant. We got a grant back in September of last year that we have some monies to provide some different medication disposal kits and medication lock boxes to the community, free of no charge. If you if you need anything to be able to dispose of your medications, if you need anything to store your medication, if you need somewhere to go and dispose of your medication, we have those resources, and we also share with Scotland Health Department, and also the Lombard Police Department and Sheriff's Department. But just a couple of things that we have that we would love for you all to pick up tonight and get. This is our medication lock box. We usually try to gear it toward our middle age going into our older age towards maybe 70, early 70s. Because we want people to be able to store their medicine safely and store it properly. A lot of times we've been having, well, not a lot of times, all the time, when we have been seeing that a lot of people store their medications in their house where people can get to. A lot of times if you've gone to, a lot of your family members' houses, their medication is sitting right there on the table, or, it's in reach. And we've been seeing that a lot of the overdoses and stuff that has been happening is because the medicine is in reach. It's accessible to anyone to be able to get. Yes, especially children. And so we are trying to get people to store their medicine safely. With the lock boxes, it has a code on it. Just remember an easy code that you can, remember and store it somewhere safely in your home. You don't have to hide it somewhere and then you can't even remember when you get it, but put it somewhere that you can be able to store it, and then, it's safe from others getting it. I remember, years ago when I would go to my grandmother's house, we wouldn't allow it in her room. We could go in her room. So if you have a medication store, a storage box, put it in your room.
your grandchildren, your children will not go in your room and get that. Also, we have a nationwide campaign, and it's through North Carolina, and it's called Be Aware, Don't Share, Lock Your Meds. I'm sure you probably heard it on the radio, or seen it on TV, or just seen it advertised on billboards or things. And it's just getting the word out of locking your meds, making sure that you're keeping your meds safely from your children, people that come in your home, because sometimes we do have visitors in our home, and we don't know if we turn our head for a second, they could be rambling through on our tables and things. So just be careful, keeping your medicines out, just store them properly. And lastly, this is one of the biggest things that we have been trying to get out to everyone in the community. The reason why we said before, is a lot of times people are getting, medications are more accessible in homes. And the reason why is because people don't know where to, people, I'm not gonna say where, but people sometimes just don't know where their medicine. Or they don't know, they just, keep the medicine for my mom, and she's had medicine that kept, I'm 34 years old, she's had medicine that kept probably longer than I have. And I'm like, Mom, oh my God, you got to get rid of this medicine. And so this is a convenient way. It's a medication disposal kit. It's called a Terra. It's a deactivation system where all you have to do is take your medicine, pour it in here. You'll pour fill the pouch with warm water halfway. It gives the instructions. I'm talking as clear as day. And then you shake it up. After you seal it back up, it's like a Ziploc bag. You seal it up, shake it up for a little bit, and then poof, the medicine is gone. So a lot of people say, well, it is like, what do you do with it after you get done? Throw it in the trash can. Now, a lot of times we've been saying, don't take your medicine and throw it in the trash, because we have had incidents where people have been roaming through trash trying to find medicine. I ran up on an incident where me and my father ran up on an incident and the man was in the trash can trying to find pills. Had a whole bottle of pills on the side. So that's why we're telling people not to throw it in the trash. A lot of people use cat litter or, coffee grains, which is, okay if that's the way to be able to deactivate your medicine, that's fine. But this is a safe way we know. And it's like a charcoal substance, and nobody can. If you, try to get in this and try to get medicine, I don't know, something's going on. So all I know is that this is a very safe and convenient way to be able to dispose of your medicine safely. And these, we have plenty. And we would love for you to get them. Don't just come up here and get, like sometimes, someone will say, well, just get one for you. No, I want you to get one for you, your mom, your dad, sister, everybody, because we have plenty, so that we can get this out to the community and let people know that, hey, we have resources that you can be able to dispose of your medicines safely in your home. Because we do have drop box locations. We have one in Lombard, at the police department. And then there are some, we have some in Robinson County. There's one in Maxton, if I'm not mistaken. But sometimes everybody can't get their medicine in. And then we've been seeing that sometimes when people are wanting to take their medicines and drop them off, they forget, and they're in their car, and if they get stopped, what happened? They got medicine on them, and they're like, where you going with all this medicine? And especially if it's not yours. So these are convenient ways to be able to dispose and store properly your medicines.
And I will share with you all, the Scotland County Health Department is collaborating with Robinson Healthcare Corporation in order to go out into the communities to share and to educate people about this. If your church or civic organization wants to have a program where we come in and talk about the importance of disposing your medications properly and why, we will come and talk to people in a group setting and work together and provide those lock boxes and or the doTERRA at the same time. So we do appreciate anyone who wants to, that this is another wonderful resource and another collaborative effort, because there's so many people here in Scotland County that do not know of all the resources that are available to them right now. You see just a handful of us right here, but there's so many more resources that can be available. And I know that by word of mouth, is so helpful to us in getting this information out. So with that, I guess we're going to turn it over to our keynote, and Kevin. And
One thing I do want to ask about, how many of you are familiar with Skittle parties? Skittle parties? Yeah, I wonder why you are. And I'm sure the name has changed 19 times since I learned about them. Skittles parties. There were teenagers or whoever get together. They raid someone's medicine cabinets, their parents or grandparents or whoever, and they take whatever medications they find and they take them. They go to a party and they all go into a bowl. And, you know, the parties I go to, everybody brings a cheese ball or a dip. But they go off, and throughout the night, people come up and they take something. It might be a cholesterol-lowering medication. It might be something to regulate your heart. It might be a Xanax. It might be something that will go off and is fine for that 70-year-old who has a very specific health condition, but for a healthy 20-year-old is quite dangerous. So things like this is also very beneficial for those people who are, hold on, I take medicine for my heart. Nobody wants that, you know, but someone may take it accidentally. My wife is an elementary school teacher, and just one case that she knew about, there was a kid at her school that came in one day, and one of the teachers noticed the child was playing with something. What do you have? A piece of candy. Let me see. It was a little brown piece of candy as far as the kid was concerned. However, when the teacher took it, recognized that it was not, the school nurse could still read the indication and the numbers on the side of it. So the school nurse was able to figure out fairly quickly that if this 50-pound child took this, they would have hopefully been able to have an ambulance right before they passed away. And it was just a piece of candy as far as the child was concerned, or at least that's what they said. But it was not intentional, but at that point in time, if that child would have put it in his mouth and swallowed it, we probably would have had a fatality at a school. So sometimes some things that may seem very simple can be life-changing. And with that, I'm actually going to ask Dr. Lowry, with the healthcare system, and really what are some of the benefits, or what are some services that our hospital and their extended services provide?
Good afternoon or good evening. Thank you for this invitation to come and speak with you. So, as I said, I'm a family physician by training. I spend many of my days now as a CMO at the hospital. And so just to give you a little picture of kind of what we've been dealing with or dealt with over the past few years, definitely more fentanyl overdoses in our ER. Just this week, we were listening to our daily safety call, and our nurse leader on our labor and delivery floor reports that they are seeing increased incidences of women locking themselves in the bathroom for extended periods of time because they are using fentanyl shortly after birth or while they're waiting to deliver, et cetera, et cetera. So the hospital is not protected from this epidemic. Neither is your community, our homes, our streets. You know, it really has no respect of person when it comes to age or demographics or, you know, as Kevin said, how much money you make. It doesn't matter. So that can be a blind spot if you are just looking, if we as physicians or we in the healthcare system are looking for a certain person. You know, that's our first problem. We do standard screening. If you've been to the doctor, you've been asked, do you use any illicit drugs? Some people will say yes. Some people are honest. Sometimes we get so used to those standard questions, we don't even always pay attention to the answers. sometimes in healthcare you're pressed for time, not sometimes, oftentimes, especially during a pandemic when you have, 30 people showing up because they're sick and they need to know if they have COVID. Unfortunately, the substance abuse problem didn't stop, probably got a little worse, and we have these competing issues going on, and we weren't able to give it as much focus as it needs. So I say all that to say, rapid responses are called, and, in a hospital, something's going on, there's been a change, there's been an alteration, and probably at some point years ago, those were oftentimes strokes or heart attacks or, some respiratory distress, and now it may be due to drug use or abuse or misuse in the hospital. Not because we've administered too much, that happens sometimes, but that's not intentional. But oftentimes it's because we're giving them things, we're treating their pain after a surgery, but guess what? Family or friends is bringing it in too. And so, what are we going to do? Are we going to check everybody at the door? I would think the police officers agree. We don't have resources for that, but it's definitely been an issue for us. In our practices, I'm a little proud to say it is not perfect, but probably about 7 years ago, I would say, I'm not sure how long, the STOP Act legislation came out. But around that time, the medical board also, the North Carolina Medical Board got very hard on here's the detailed opioid prescribing guidelines. And I was very thankful because we immediately at Scotland and in our physician network implemented practice guidelines for opioid prescribing and said, if you're going to prescribe, you better follow these. We will be auditing it. And we do audit that in all of our physicians. So we know if somebody is not putting people on a pain agreement, if they're not checking urine drug screens per our policy, if they're not checking the database to ensure that patient hasn't been getting from multiple prescribers. Along that time, it appears word got out in the community because drug seekers often, kind of know where they can go a little easier, and they know who's not prescribing as easy. And so I would say that's been a benefit in our practices once we enforced that and kind of drew the line. And we've maintained that level of accountability and monitoring. Doesn't mean there aren't prescribers in my system that still beat it somehow or are not appropriately prescribing, but I would say we do a great job if we were compared up against some other folks because we're following the guidelines. So for us, the STOP Act, the medical board, it almost empowered providers a little bit to be able to say to a patient, here's how I do it, here's why I do it. It doesn't matter if you're 83, it doesn't matter if you're 23. Here's the rules, and there's no ifs, ands, or buts. And so that is how we do it in our practices. We have had a couple instances of patients who have shown up and we might have had more of a rapid response or a code in our practice. It wasn't very often. I mean, over my 10, 11 years, it's been a handful in various communities. But we don't see that a lot, thank goodness, but you better believe a few years ago, we equipped our emergency boxes with Narcan, which we did not have to do before. That was more of in the hospital, but it's there now. But thankfully, in our practices, we're not using it a lot. And I attribute it a little bit to the fact that we're not prescribing. We have a boundary on what we prescribe over. But again, people have it, they get it from other ways. I would say the downfall to not prescribing as much, and this is kind of very ironic to say out loud, but when we were prescribing it more often, opioids is what I mean, when we were treating chronic pain more often, it gave you a chance to talk to people and try to dig down and talk about it. Once you begin referring patients to a pain clinic, then you, as their medical doctor, sometimes you don't go there. The pain clinic handles it. They're not talking to you about it, so you're not always talking to them about it. And I would say that's a barrier in healthcare because especially as a primary care physician, even though I'm not prescribing it, I should still initiate that conversation. Because sometimes the pain clinic's not going to, right? especially depending on the quality of your pain clinic. If they're in it for the wrong reason, and some are and some aren't, and I think many of us physicians that have a passion about this, which is most, they know who to prescribe to preferably and who not to. But patients also can make self-referrals, so sometimes they'll go wherever they can. But talking to patients, especially patients who have been on opioids, chronic opioids for pain for years, they've never had somebody talk to them about, hey, you ever thought about getting off? And surprisingly, some will. I have seen them come off because we initiated a conversation. We told them that studies show 5 years later, you're more depressed and your pain is no better than it is right now. Before you got on, you're actually worse off. And they've just never even tried to come off. Like, nobody's talked to them about it. And so once in a while you'll get those successes. So for us, prevention starts with, number one, being very judicious in prescribing, because as all of you know, most likely, some people become addicted because they broke their arm. You know, they had a surgery. And this is where it gets into, it doesn't matter who you are. You didn't have to grow up in a community where all you saw was people addicted to drugs. You just went for a medical procedure, and they gave you 50 pills, and you took them because they told you to take them. And, you know, learning, and again, legislation helped this some to say there's a limit on acute pain, and you can only write this much, and the pharmacy is only going to fill. So legislation has helped that, but I think a lot of physicians are also more open to, hey, you broke your arm, I'm going to give you 7 pills, and we're going to follow up and see where you are, and it's made an impact. So never creating that opportunity, number one, is what we try to do, and balancing that with treating pain is hard as a physician, because we're also taught not to ignore that. And when you come to the doctor, what are you also asked, in addition to do you use drugs or illicit substances? Tell us what your pain is. I mean, you could be there for just like your blood pressure or your cholesterol checkup, and you're like, rate your pain today. Everybody's like, who said I was in pain? But that's like the 5th vital sign. We have to ask it, or we get deemed. So, you know, for physicians, it's always this, we gotta not do this, but not do this. But I think that has helped a lot. And I think if we're gonna get to prevention, it's about having that discussion, not just saying it's a pain clinic problem, it's my problem too. And people trust their physicians usually. I mean, that's why they're still going. That's why they chose them. And so I think we can make a difference. As far as services, that's where we lack in healthcare, obviously. I mean, y'all are great, and y'all are talking about things I've never even knew existed, you know, close by. I figured they did, but we don't have this list of here's who we call when, and they can easily do this. So we're limited, our ED, but also our practices, by what are our resources. Because we can tell patients to go call East Point, or sometimes we can call, you know, depending on the situation in our practice, and that's great sometimes, but then sometimes that connection is never going to happen, and the patient just continues. So just like going to their community and doing the outreach, because they're more likely to come where it's private and nobody knows, we also believe that embedding mental health, behavioral health, substance abuse programs in our primary care practices where they're already coming for their regular checkup empowers people to utilize the service. So we have a licensed clinical social worker who is also certified in substance abuse counseling, and she rotates at each of our primary care practices except our South Carolina site, and our plan is to hire a second one. But she is there in those practices at least 1 day a week. We are able to refer patients. If you don't have insurance, it doesn't matter. If you do have insurance, we can bill that. And I've been pleasantly surprised, but I kind of figured this would be the outcome. Patients are willing to go. I mean, whether it's to get their depression addressed through counseling, when they thought it was a stigma, if I would have said psychiatrist, or even if I'd have said go to Scotland Family Counseling, it's like going somewhere is like, I don't know about all that. But when they can just come to their regular doctor's office and see that counselor, they're much more willing to. So people who are 50 and 60 years old that never would have dreamed of talking to a counselor are doing that. And they don't feel like that stigma is attached as long as it's in our practice. So having that person who's also certified in substance abuse counseling is very helpful, but this is just the tip of the iceberg, and we need to clone her like 5 times, right? Because we need her in every practice every day so that the physician can do their part, get out of the room because we got another patient to see, but let the counselor who's better trained in getting to the root of some of this deal with that. And, you know, we do not prescribe any medications. We don't have anyone that does Suboxone or anything like that, at least in our primary care practices or within our health system. And so I think the medication management part is an area we could improve in, that we here in Scotland County or in our practices in Robinson don't have that readily. However, we did get a behavioral health grant with ECU through the NC STEP program, and we're partnering with them to not only have our counselor, but they will provide telepsych services embedded in our practice. So we'll have a psychiatrist. So oftentimes mental health goes hand in hand with substance abuse, as we know. And while we do a ton of treating of major depression and anxiety, but when it starts getting a complicated depression with psychosis, or when we go to bipolar and schizophrenia, it really becomes a lot more than the primary care physician can handle. And you need a psychiatrist. So this would give us the opportunity, while the patient's there, they could be actively hallucinating or in a state of psychosis, to bring the computer in, set it up, and have the psychiatrist there, who would then consult with us and say, here's what I recommend, prescribe it. We're going to do it because we're consulting with a specialist, and then we could, you know, on demand treat those patients better. And through that, there may be some opportunity also in talking with them for more of the medical treatment side of drug abuse or substance abuse. So we're excited about that, and we hope to have that by summer implemented in our practices. So that's kind of current state. We still would love to know more about these resources, and we also hired a community health worker who knows the community, and she works with the ED and she works with our primary care. And so her job is to go out and these patients who may be frequent utilizers, oftentimes they've got barriers which may or may not include substance abuse, but she goes to their home, of course, you know, gets permission, and they develop more of a trust with her, and then she's able to bring it to the physicians and say, hey, here's some of the things we need. And I'm quite sure she is fully aware of some of these services I've heard about tonight. But getting more people like that who can work with the physicians is what we really need to focus on, and what we're trying to build a program. Working with community paramedics, you know, we just think that navigating patients through the system is going to be the way we get more done, because it's not just about the doctor, the nurse, and the patient anymore. We need help. You know, we need all these resources working together. So, you know, that's current state, and then there's future state. But the problem's not going to get any better until we get really creative as a community on how to solve it and address it.
Now, also with that, if someone is suffering with it and they want to go off and have a conversation, I'm using illicit drugs or I'm overusing medications, and I bring it up to my primary care doctor, you know, are they going to call the police on me? You know?
No, you know, the only time we would call the police, and usually it becomes in the form of an IVC, seeking, you know, IVC or involuntary commitment, is if you have a patient who is actively suicidal or homicidal in your presence. They're admitting that is the case, and they cannot, what we call contract for safety. They can't look at me and promise, I'm having the thoughts, but I know if it were to get worse, I would call my friend or I would contact you. You know, when they can verbalize that and you can document it and y'all contract for safety, it means their judgment's still intact. When they can't do that, then you got to intervene on their behalf, and that's where the IVC comes in. So usually that's the only time we're contacting, you know, a level of authority. You know, otherwise it would be if a patient would come in on drugs or actively psychotic and hurting someone. That'd be the only time we call the police. But no, from a confidentiality standpoint, just opening up and saying what you do, no, it's confidential. And we would not do that.
But at that point in time, that can start a conversation with that primary care
Right.
doctor who they trust.
Yeah.
And they may not be the resource, but they can help find resources.
Yeah, absolutely.
And after that, because I noticed you talk about having locks on in our crash cars, or in your response kits. And that is something that the county public safety has done a lot of. So I'd like Robert Sampson to go off and kind of give us an update on public safety.
Thank you, Kevin. Good information, Dr. Lowry, that you're sharing with us. I'm just going to take just a few minutes. I want to share some data with you from a local level as well as the state level, and then I'll real briefly talk to you about Narcan and naloxone, the purpose of it, and how you would use it. I'll actually do a quick demonstration for you. But the data that I want to share with you this evening is overdose data just in Scotland County for starters. In 2022, first responders responded to 217 overdose calls in Scotland County for 2022. And out of those 217 calls, Narcan, this medication right here, was administered 184 times. Now that does not include the times that Narcan may have been administered in the emergency room setting after the patient was transported to the hospital. This is just pre-hospital administration, which was 184. For our small community of 34,000 people, those are large numbers. Okay, those are very large numbers. So now just to share with you some state data. Suspected overdose of death in 2022, from January through August of 2022, there were 2,763 suspected overdose deaths in the state of North Carolina. Fentanyl deaths in North Carolina in 2022, from January to June, half of the year, 1,677 deaths for half of a year in 2022. So I hope these numbers will just solidify our purpose and the reason why we're here, okay, and the movement that we're trying to make, okay. So those numbers came straight off of the North Carolina Chief of Medical Examiner's website. So feel free to go on their website. There's a lot more information out there from the state level. That if you have any interest, they do share a lot of the data right on their website. Okay. So real briefly, I want to talk to you about Narcan, or naloxone, as some people may know it. This medication is used for one purpose and one purpose only, and it is suspected opioid overdoses, okay? And I said that very specifically because it is that specific, okay? Narcan, if you suspect someone's taking too much Tylenol, or they've gotten into grandma's Valium, this medication is not going to help that person at all, okay? The medication is only for suspected opioid overdoses. That would be your fentanyl, that would be your heroin, that would be your Tylenol 3 with codeine. Any medication that falls into the opioid class, this medication, it can be very helpful. So a little bit about the medication. In 2013, the state of North Carolina deregulated Narcan. So what does that mean? That means you no longer have to have a prescription that the primary care provider would normally have written before 2013, no longer has to be written. So since 2013, you do not need a physician's order to be able to get Narcan, okay? It was deregulated, and that was all done because of the opioid crisis, the synthetic opioid crisis that was beginning during that time. So now, if you have a concern of a loved one or family member that you suspect is using opioid medications, you can go to any local pharmacy and purchase this now, right over the counter, which is good. So when would you give this medication? Remember I said it's for suspected opioid overdoses. So some of the signs and symptoms that you would look for is if you have a loved one or a family member, or you come in contact with someone that is unresponsive, and you're noticing that they are having a severe decrease in respirations. Okay? Those two things are key. All right? If you suspect that they've taken some pills, okay, but they're in their normal state, then you don't want to administer this medication. Not at that time. But if you suspect that they've taken some medication and now they're unresponsive, okay, and you notice that they're not breathing normally, okay, when I say normally, just like we would normally breathe, they're breathing, 8 to 10 times a minute. They're making noises whenever they're breathing, okay. You notice that they're clammy, all right, they're wet, okay. And you suspect that they have taken fentanyl or some type of opioid drug. Okay, let's say you see needles laying beside them. Okay, this is the time that you want to use this medication. Okay, so real quickly, I'll demonstrate how you use it, and it is very simple. This is the actual Narcan that you would get at a pharmacy. Okay, and it actually comes with two doses. Okay, each dose is 4 milligrams. And you would actually just squirt this right up their nose, okay? This is given what we call intranasally, all right? So as they are breathing, the best way to give it is whenever you watch them, and as they're breathing, when they get ready to inhale, you take the white part and push it up their nose, and then the red piece is the plunger, and once you put it up, you simply squeeze, okay? Now you just administered that medication. All right? Keep it in mind, when you administer it, it will take a couple of minutes. It may take 2 to 5 minutes before the medication starts working and starts reversing the effects of the medication. Okay? Once that happens, you should start seeing improvement. You should see them start breathing better, and they may even start waking up. Okay? And that's what the medication will do. It actually stops the effects of the drug, and it starts reversing. Okay? It is a very safe drug. This medication is very safe to give under the right circumstances. Okay? Again, just remember, if it's not an opioid, this medication will have no effect whatsoever. Okay? Any questions? Yes, sir.
So you meant that first one, but if you don't respond, do you go to the second one?
So what I like to tell the general public, like I say, you have 2 doses, okay? If you administer the first dose of the nose, you want to give it time, okay? It's not going to work in 30 seconds, okay? You got to allow 2 to 5 minutes before you start seeing the effects. Once you get past that 5 to 10 minute mark, if you're not seeing the effects of it, there is another dose that you could give, okay, that's in there. But hopefully by that point in time, we have been notified, you have called 911, and we are on the way, okay? And hopefully in 10 minutes, we're going to be there. And then you let us take over, and then let us administer that second dose if it would be needed. Okay, because we can assess our patients and make that determination if an additional dose is needed, because we have protocols in place that we may not give an entire 4 milligrams. We only may give half of that dose, okay? And that may be all it takes. But to answer your question, you do have 2 doses in there. You don't want to give one and then in 2 or 3 minutes you're giving the second, okay? Because you can give too much, okay? So you want to give it and allow time for it to work. Okay? I hope I answered your question.
But an important part of it is that can also help. That gives the 8 minutes it takes on average for EMS to arrive. Mm-hmm. That helps them out tremendously.
Absolutely.
Even if it doesn't wake them up.
Yeah, and if it doesn't wake them up, it's okay. The emergency is not the fact that they're not awake talking to you. The emergency is the fact that they're only breathing 4, 5, 6 times a minute. If we can reverse that, get them to increase respirations, then the goal was met. It doesn't matter if they wake up, okay? What matters is that we improve respirations.
What would happen if you missed up, not you all, like us lay people say, oh, I think they did take opioids, and you give them that, but they've really taken Tylenol. What's it gonna do to them?
Nothing.
Okay, that's good enough.
Nothing? Yeah, because, and the reason why I say nothing is because of the way the medication works, the way Narcan works in the brain, to the opioid receptors that's in the brain. So if there's not an opioid in the system, then there's nothing for Narcan to attach to. Any other questions?
Y'all get anywhere in the county in 8 minutes?
I'm sorry?
You can get anywhere in this county in 8 minutes?
Right now, yes, sir, we can. Now that we've added on additional ambulances to our service, and if you're a resident up here in Wagram, as you know, there's now an ambulance up here in Wagram. So that has reduced the response time dramatically from us having to respond from Laurinburg. So right now, we're in a good shape to where as long as we are available and all of our units are not tied up on other calls, yes, we can be anywhere in the county within 8 minutes.
So if you go off and you see a paramedic walking around the building out here or in this hallway, please note, they're not goofing off. Fortunately, they're not needed anywhere because their day room is right over here for this ambulance.
Yep, it's just on the other end of the building.
So I live across 501 in the Morrison area.
Yep.
You can get there.
Oh, yeah.
Yeah, you can. That is fine.
Yes, sir. You're taken care of, I promise. Any other questions?
Robert, I've got one.
Yes.
Can you talk just a little bit, just for awareness, about what the protocol would be for an adolescent versus an adult that is suspected of overdose? How you would respond to that, and would it be the same in terms of dosage or the wait time? Can you just talk a little bit?
Yeah, so the dosage, in your case, if we're talking about a teenager, 14, 16, 18-year-old, your dosage is going to be the same, okay? Now, if we start getting into our children, okay, our toddlers, okay, then 4 milligrams is going to be too much for them, okay? And unfortunately, with the way this is designed, you can't give half a dose, okay? It's an all or none. So if you're in a situation where this 2-year-old has gotten into someone's medication and possibly has taken some Tylenol with codeine, the best thing you can do is just call 911, okay, and get us on the way. Because will they possibly need some medication? Yes, but the dosage does change dramatically, okay? So, and of course, we have protocols to follow with the proper dosing so that we make sure that we don't give too much, okay? Now, as far as wait time, response time, as far as the medication to work, it's all the same, okay? And I can't sit here and tell you, once you give the medication in 2 minutes, you should see a difference, okay? Because it does not work that way. There's a lot of variables that you have to consider. Age, weight, how much of the medication that they took, okay? Because what we're noticing, and I think Dr. Lowry will validate this, what we've noticed over the last couple of years is that it truly, at times, it's taken more of the Narcan to get the same desired effect. The reason why we think that's happening is because they're taking more and more and more of the drug to get the same high, if that makes sense. So now we got more of the drug in the system, and unfortunately it's taken more of the Narcan to reverse the effects of it.
Which is why we also have more fentanyl-flavored funerals.
So, good question. Did I answer your question?
That's my question. Thank you.
Okay? Thank you. And I also just want to, if you have an interest in wanting some Narcan to take home with you because you have a loved one or family friend that you are concerned about, please see me. I have some. I would love to take that empty box and throw it, or take that box and throw it in the trash because it's empty. Okay? So if you feel that there's a need that you would like to have some, please see me.
I got a question.
Yes.
If a person was to make a mistake and give 2 of them, is it a charge behind that because they shouldn't have gave them 2 or they didn't know out of ignorance?
When you say charge, you mean legally?
Yeah.
No, sir. No. And the reason why, I say no, and we do have a representative from the Sheriff's Department here. The reason why I'm telling you no is because there is a law called the Good Samaritan Law, okay, that will protect you in a court of law. Because the Good Samaritan Law says that you were acting in good faith, okay? And if I wish I had that, those terms are in the law. You were acting in good faith to try to help.
And sir, I have handouts that explains the Good Samaritan Law right here, along with other information, if anybody would like to take one and have it on hand. I think this is so important.
Yeah, and that is a very good question because more times than none, people hesitate to help for that reason.
And that goes for law enforcement. Nobody's going to come along and arrest you. That goes for also civil litigation. If I were to fall out right now with a heart attack, Robert would start CPR on me, which means he's going to break several of my ribs. And I couldn't sue him because of it. Because you as a layperson, you are absolutely protected from that as an ordinary person trying to provide reasonable aid.
Yes.
And again, Narcan, it's useful for somebody who takes fentanyl. It's also useful to have if you have somebody who is appropriately prescribed medication and is intentionally trying to take it appropriately, but they had that confused moment, they take the wrong medicine. They put them in the wrong pill organizer. Something like this. This should be happen if you have someone who regularly takes most of your pain management medicine is opioid based. And having something like this in the home, it should not be a status symbol. No. It should not be something to be ashamed of, but it should be something that's common in a lot of people's homes.
And two, I'll share with you some of the protocol changes that were made over at a 911 center. Now, if someone calls 911 because of a loved one or a friend that they're calling for, they suspect it has had an overdose. One of the questions that now is being asked, is there Narcan in the home? If there is, then they go through step-by-step instructions on how to instruct you on how to administer. So please don't let it be a stigma, please. You know, because
I know a lady that goes to Fort Bragg, and she does take Percocet, has for some years now. She's 83, and they give her Narcan.
yes.
It's very standard and
Yes.
pain. I mean, in fact, I believe it's part of the regulation.
It is.
It's required.
When I realized that, I'm like, why do you have that? You know, because, and you do want to sort of stigmatize people.
Right.
You see that, but now I know it's, you know, they could get confused, like you said, at that age, and do overtake their medications and not realize it. So it's actually a good thing to have.
People can overdose off of, what you said that word, that pill was?
Percocet.
Percocet. They can overdose off of that too?
Oh, absolutely.
Oh,
yeah.
yes.
Percocet is an opioid drug.
Yes.
Mm-hmm. Yes, sir.
So, and that's their help.
Yes, sir.
And that's one thing about it with it and talking about, well, why do I have fentanyl? Actually, my wife and I were talking about this. We need to have a conversation with my daughter because my kids are in college. My daughter's in a sorority house. I need to find out, hey, do y'all have some Narcan in the sorority house? If not, I'll get you y'all put it and keep it in the kitchen. It needs to be very normalized. I know of a number of people who who've been struggling with this in their families. They've gone out of town to go to Al-Anon meetings, basically an AA meeting, but it was supporting family members because they were ashamed to say that they were having this issue. Again, out of town, they walk into the room and they knew half the people in the room. I had some own mental health services for my family that we were going up to Moore County for, just because the services were available there. But I was sitting in the waiting room, and I knew a third of the people who were coming and going. So it is something that we need to make sure that we do have open and honest conversation in the community. It's a whole lot better to have conversations now than say, what a shame, after a funeral. Anybody here have any questions or comments or anything you would like to make? We have some people who have great information, and I'm not one of them, but you have the chief medical officer for the hospital here. You have our public safety director here. You have experts on mental health.
Well, I got a comment.
Okay.
I think this is one of the things y'all done. And I think this community needed.
And two, one of the things I failed to mention, we talk about fentanyl. Fentanyl is becoming the number one drug that people are overdosing on. One thing I think is important to know is people have asked, well, my God, where's fentanyl coming from? You need to know that the fentanyl is not coming from Dr. Lowry and her counterparts writing prescriptions for it, okay? Matter of fact, they can't even do that. Where fentanyl is coming from is this person that gets on Google at 3 o'clock in the morning how to make fentanyl. And they get all the ingredients that they need. So they go out and they make it themselves, and it's called synthetic, okay? But where they fail is they're not a chemist, and their garage or their basement is not a laboratory. So they're making this fentanyl, knowing or not knowing that fentanyl is so potent that fentanyl is given in a controlled environment in the healthcare profession in micrograms. There's no way that these people know how to make it and then make it in the right dosage or in the right formula and format for it to be safe. So the reason why they're overdosing is because this synthetic medication that's being made is so potent that the body cannot withstand the dosage that they're consuming.
I think a good example of that is, as many of you know, but hopefully no one has experienced, cancer pain is one of the worst pains anyone can, deal with in this life, particularly bone pain from cancer. And so those patients often require a very high dose of medication. And we were taught, when I was in training with hospice patients, that we didn't increase fentanyl doses for 3 days while we monitored them, because you never know when it's going to take effect, and you've got to slowly, so you start at the lowest dose and then you up titrate after 3 days. Well, the average person who's using this doesn't know that, which is why they can take it one time and it's lethal.
I have a comment, but say, is it possible to come up with a flyer with these different organizations on it and being able to reach out to the community for the next meeting?
Yes.
In the Scotland County, if you could, it's like one person can run for county commissioner and he police the whole county. So what we need to do is start policing the county for the next meeting. And that way we can reach, we may not, we can be able to reach families that's dealing with these same kind of circumstances. We can have a flyer made up with these different organizations on and being able to give them to some of the churches and put them in the community. And by the time the next meeting, it may be triple the time, the number of people that we have here.
Now, with that, we do have flyers, and for these meetings, we've been publishing them on the county's Facebook page. But that, and if there's other organizations, you know, tell us the organizations, tell us the groups. We want the information to be at your bridge club, but if Parks and Recreation puts it on the wall, you're gonna miss it 90% of the time. But if you bring it in there, the other three guys at your card game are gonna notice it. And I'm saying that because I believe they were in here playing cards with one of the groups. So, yeah, so, but if one of you bring that in there, it means a lot. But if Brian Graham brings it in there, you won't read it. But we absolutely want to push it out there, and we will continue to push it out there. And the more partners we have sharing this information, the better we all are.
Yeah, we need invitations to go and share information at these churches. We need to be invited when you have a community day event, or if you want to do a spotlight, or ask us to come and speak one afternoon, or I go when I can get an invitation, and I do make contact, and I do offer, and it's like, well, we'll pass that on, okay, but there have been lots and lots of invitations, there have been emails sent, there have been phone calls made, there has been just stopping by places, but we need for folks that truly have an interest to bring it up and say, hey, why don't we have somebody, I'm worried about this, we need to get the message out to these families. And it takes somebody willing to push it. Part of the pushback that we get as we try to reach out sometimes is that there's this idea that somehow we're trying to sell something. We don't have nothing to sell. We don't have things to sell. These are programs and services, and as far as what I do all day long is go places and talk and give information and try to raise awareness. But I want to be busy all day long every day. There's a lot of other things that I wind up doing, but I would love to be so busy that they have to hire a whole team of me. That's how busy we need to be in order to be as effective as we need to be.
I will also share that we have a health and wellness resource guide. The hospital has one, the health department has one, and it's from A to Z. We have all kinds of resources, phone numbers, addresses, in our community health and wellness resource guide. So if you want one of those, reach out to the health department, tell them you want to talk to one of those health educators, that you want one of those wellness resource guides, and we'll make sure that you get it. We have them in the front in hard copy form. I didn't think to bring one tonight to show you, but I know that the hospital also shares some form of a wellness and resource guide as well. And so they're out there. we have flyers that we can provide the churches that has the specific education. We have things, tips for teens, that you all can maybe reach out to your teen in your churches or in your civic groups or in the Girl Scouts, Boy Scouts, those kinds of things. We have things, if you know anything about opioids or crystal meth or the Good Samaritan law or prescription opioids and looking for the signs and symptoms. We have all of this here and readily available to share with anyone who asks for it. And like Susan was saying, we are here, we're educators. We are here to help educate people, to inform people, to provide resources that are available right here in Scotland County. There's so many people that we miss and they don't know what's available because they don't know where to go to ask for it. So this is just the tip of the iceberg, so to speak, that there are resources. Find the right people. Go to public health. Go to the hospital system. Go to these agencies that are here tonight. East Point. You have RHCC, the Robinson Healthcare Corporation. You have Stevens Outreach Ministries, thank God, with that mobile unit. There are resources. It's just a matter of people other than the educators educating their immediate family and friends about what's out here. Because hopefully at some point we will be able to reach someone who needs.
And listen to Live on Main Street. We've both been on that many times to share information. And so it's a good resource.
Now, also one thing, and Dr. Lowry mentioned this earlier, you know, a lot of times this resource knows something, but that resource doesn't. So actually, and we started to get together as specifically as agencies to try to find out some of those flaws, and found that that was a problem that we were having. And so social services came up with the idea, with the support of all of our other partners here, about creating a coordinator, somebody who can, when East Point is having this or the hospital is having this, they can also not just reach out to East Point, but reach out. And we have a coordinator who knows how to touch different people's lives. But that, and just so we can actually, it's easier to create that spider web or that roadmap of services. And also another person so that when your church has a funeral for someone, afterwards, contact, and you know what? The Wednesday night afterwards, your next Wednesday service, we know somebody who can come in and talk to you about services that that family may need. Other people in the family, other people who honestly are the next funeral in waiting, because really that's what we're talking about. You know, we can go off and see about go ahead and getting those services to people before they lose a child, before they lose a husband, a wife, a father, a mother.
You know, Kevin, you bring up a very valid point, and Dr. Lowry, thank you so much for integrated whole person health. And I'm so thankful that we have moved in that direction through the years, and we have learned at the expense of patient care by not being on board with that. That's important to look at a person as a whole individual. Their mental health is important. Their physical health is important. All of these things work together. April, you work with children every day by the masses, and we know ACEs, those adverse childhood experiences, how it's directly related to healthcare and stuff. And we sit, like Kevin said, and we suffer and we die in silence because we will not go to a support group meeting here in Wagram, but we will go to Lumberton only to find all our neighbors are there. And why is that? It's because we are ashamed. All of us feel shame at some point in our life, but we should never feel ashamed. And that's one of those situations because of stigma. And tonight we need to say that no more. We do not have to be ashamed that we're suffering in our mental health status, that we're having anxiety, that we're having depression. We're one of the most richest countries in the world, but yet our own people are suffering and dying because of ignorance, because we will not embrace it and say, I refuse to be ashamed that I struggle with depression, but if I had hypertension or gout or any other condition, I would get that addressed immediately and go to the doctor. But we will not address depression because we don't want to be labeled as one of those individuals that somehow is not well or healthy. So let's stop that nonsense. You know, we're available at East Point 24 hours a day, 7 days a week. Like Susan said, we don't have anything to sell you, don't want to sell you anything. We want to connect you and make sure you get what you need. Please pick up a car. You know, take care of your mental health. You know, we're integrated and health is important. And we have to be healthy all the way around.
And
General wellness.
just like with myself, I'm a peer support specialist. We go into the individual's home. They may be experiencing depression, anxiety, drug abuse, opioid use. We don't know until, we read their PCP and we read about them. And we go into these homes, and a lot of them, like you said, they won't go into a public setting. But now when we go into their homes, we can make that big difference. So if you know somebody that is suffering even depression, just like myself, I've got several people, they're on the road to recovery now. Just by me going with them, talking to them, giving them resources, coping mechanisms. That's the big thing. How do they cope with the anxiety, the depression, the drug use? How do we, if we have a trigger, what do I need to do? That's my job. I'm teaching them what to do. And that we need people. If you know anyone, tell them, please come in for services. I mean, we will go to your home. I go to my individual's home. They don't come to me. I go to them.
Any other questions, comments? Anyone here?
This is, I don't know how to say this, but I think that the churches is not understanding in a certain way. I say, I pastor a church in law here, and to them, reaching out to a certain level of pastor, reaching to the organization for help. I have had young men in my churches that was on drugs, and because of God, He got them off. Don't get me wrong, don't understand that. But they ought to be able to understand the same way to go to the organization is the same way going to the doctor for help. When the church and the people can understand that, you know what I mean? And the thing is that everybody is not going to come to the church for help. So therefore, when they can get it in their mind, the same way that God bless you with that car to go to and fro, He can bless you with this organization here to help you also. So I think that's one of the things that it's not taking nothing away from the church because you open up your door or because you allow one of the organizations to help some people that's in your community. And that's the thing about it, they can being able to see that this is to help people in the community. And if they can help them, you can be there when they come out of it, when they get through, to be able to reach out to the person and listen. While you not dealing with that circumstances you were dealing with before, make a commitment to the Lord. You know what I mean? But being able to let them understand that all these organizations is to help you. They don't take nothing away from you. Because some pastors think, you know what I mean, hey, we don't need to go to them. What can they do for a person greater than what we can do for them? You know what I mean? You know, and that's the mindset. And you can't do nothing greater per se, but you can help in the process of what they're dealing with. You know what I mean? Because people could be sitting up in church with a spirit of depression. and not really realize it.
So would you recommend that we have an event, something like this, but specifically target the Ministerial Alliance?
Well, I think that it would be good to get in contact with Ministerial Alliance
Okay.
and let them know what you're trying to do in the community.
Okay.
I meet with 13 pastors, pastor from Northview, pastor from yeah, right. But I meet with pastor from Shoemaker,
Right.
you know what I mean, and New Hope pastor. I mean, you know what I mean. It would be good to be able to get them to come together one Saturday morning and being able to say, listen, they got some resources in Scotland County. Because everybody's not walking with a relationship with the Lord.
Right.
But to be able to help them in the condition that they're in. And don't let pride stand in your way from going from reaching out to your organization. Don't let pride stand in your way from accepting the organization. Because all of us here for what? He put it all here for what? For help.
Right. Well, I know personally, I go to a lot of meetings, and I try to take at least one thing away from any meeting I go to. And that's going to be the takeaway that I'm walking away with tonight, is basically more a challenge in making sure we have that connection with the Ministerial Alliance coming up as soon as we can get one in, so we can get some of our, make sure that connection is made, so we start having that conversation there as well. Thank you for suggesting. Anyone else? Okay. Feel free to speak to anybody here after any of the meetings, get contact information. East Point is always, one of their primary services is the bridge to other services. They have a number that is always answered. So if nothing else, make sure you walk away with one of their pins over there, at least because it has their 800 number. But sit down, talk with them, get some of the aspects, talk with Robert, walk away with some naloxone if you have any pain medicine in your home. And at any point in time, you have questions, you have situations that you need to deal with, reach out to any of us in here. I guarantee you, I can't help you. But my job is to point you to, okay, you need to go to the hospital, you need to go to Stephen's ministry. We can connect you with somewhere that you can provide service. But beyond that, thank you for coming out, and please let people know we're going to be doing something very similar February 23rd at 6 o'clock at the Laurel Hill Community Center. So please, hopefully, we'll just fill up the entire gym there. Thank you very much.